Hi everyone, I'm Dr. Chris Armstrong, one of the emergency registrars at Royal Perth Hospital, and this is your 5 on Friday. This week we're talking about shock. So what is shock? Well, shock's defined as inadequate oxygen or nutrition delivery at the cellular level to allow normal cellular function, and that's most often caused by inadequate perfusion to those cells, although there are some other more rare causes. Now, we can break shock down into 4 general classes. So that can be distributive shock, so that's where there's loss of the peripheral vascular tone, which causes often a fall in blood pressure, so the cells are not well perfused, and that includes things like septic shock, neurogenic shock, or anaphylactic shock. There's obstructive shock, where the flow is actually inhibited from going from the heart out to the tissues, and that's usually obstructed by something like a pericardial tamponade or a tension pneumothorax. There's hypovolemic shock, which of course has many causes in trauma, hemorrhage. In medical cases, it may be due to fluid losses because of fever, vomiting, diarrhea, or poor oral intake. And then of course you've got cardiogenic shock, which is pump failure itself, which can be caused by a number of things. It can be caused by myocardial infarction, it can be caused by infections such as myocarditis, it can be structural heart disease, or it can be medications that we've put the patients on. Now, pre-hospitally, often what we actually need to concentrate on is identifying that a patient is in shock before we work backwards and try and work out what may be the cause. Now, shock is not easily defined in the pre-hospital field. It's not just a blood pressure. You can't say that there's a cut-off at one point where below which the patient is shocked and above which they are not. And so we have to look at the general clinical picture of the patient before we can decide whether this patient is shocked or not. And one of the key things that we need to work out is how well that patient is perfusing. So let's think about a few scenarios. First of all, why don't we take the older patient, a very common one for all of us. Maybe they're in their 80s, they've been off their feet for a couple of days, and you're asked to come and assess them at home. When you're there, you find that they have a heart rate of 86 and a blood pressure of 105 on 70. Now, is this patient shocked or are they not shocked? Well, it depends on a lot of things. As you're assessing the patient, you can have a look at how they appear from the end of the bed. Is the patient awake and talking to you? If there's enough blood flowing to their brain, then they should be awake and able to speak to you. And that indicates that that brain is well perfused, enough that they're able to talk to you and make sense. You also need to feel their peripheries. Are they warm and well perfused, or are they cool and shut down? And you can also check their capillary refill time, particularly centrally, to work out if they are perfusing there well or not. Now, from a blood pressure point of view, especially in an elderly patient, 105 may be very low for that patient. Maybe their blood pressure is normally 170, despite the fact that they're on medications. And maybe one of those medications might be a beta blocker, such as atenolol or metoprolol, which is stopping them from mounting a tachycardia, explaining why their heart rate is only 85. And so it's important in situations like this that we look at the whole clinical picture and to work out whether that patient is shocked or not. And if this patient has a decreased GCS with cool peripheries and a slow CRT, despite a blood pressure of 105, then there's a good chance that they probably are in shock from whatever cause that may be, whether that's hypovolemia or sepsis, cardiogenic, who knows. And they need to go to hospital promptly to have further investigations and intervention. What about if it's a smaller child? Oftentimes we don't get numbers on them, or not reliable numbers. On younger children we may not be able to get a blood pressure, and oftentimes it doesn't tell us much even if we can. And the heart rate is very variable depending on whether they're in pain, whether they've got a fever, whether they're distressed because they're away from their parents or they're frightened. And so it's difficult to make a judgment. And again, that's when we go back to the general clinical picture. What does the child look like? Is the child awake and interacting and looks fairly happy to be with mum and dad? Then that child's probably not shocked. However, if the child is floppy, less responsive than usual, cool in the peripheries, pale, with a delayed CRT, then even if they have a faster heart rate or even a normal heart rate, they may well still be shocked despite their body trying to compensate for potentially the hypovolemia that they've got because of their sepsis. And then there's the other times when the numbers may look unusual, but actually the patient is not shocked. For instance, take assessing a young, fit man, maybe an athlete, for example, who has a heart rate of 55 and a blood pressure of 95. Now, if that was in another patient, for example, an older patient or a patient who is unwell from another cause, we would get quite concerned by those numbers. But actually in this patient, the clinical picture tells us that he looks well, he's awake and talking to us, he doesn't have any specific complaints, and he's young and fit, like we say, potentially an athlete, and that may well be his normal resting observations, and so therefore we can be happy that that patient's not shocked. So like I say, it's a complex thing. It can be caused by many different types of pathology, and we need to look at the general clinical picture. The key to shock is it's a perfusion, or rather inadequate perfusion state, and we need to identify whether that is the situation or not, regardless of what numbers we may get from taking our routine observations. And so looking at how the patient is interacting with you, whether they're talking, whether they're confused, whether they're non-responsive, whether they're warm and well perfused with a normal CRT, or if they've got cool peripheries with a delayed CRT, those are our main pre-hospital indications that this patient may be shocked or not shocked. And we'll add those to the clinical picture that we get from their blood pressure and their heart rate to make a decision as to whether this patient needs to go to hospital urgently for intervention and investigation as to the cause of their shock, or whether we can take our time and, in fact, obviously in the case of a healthy patient, whether they need to go to hospital at all. That's your 5 on Friday, talking about shock.